Thanks very much for inviting me. I've been Chief Exec at West London Mental Health Trust for a whole 16 weeks. I can assure you it's really nice to think about having a discussion about something other than Jimmy Savile for the next couple of hours, concentrating on issues that are dear to my heart. Before I start, hands up who commissions or works in secure hospitals. Okay, well, I want to start by genuinely thanking you for what you've done in the last 2 or 3 years. You have in many ways laid down the gauntlet for the rest of mental health services in terms of your commitment to placing a priority on the physical health care of people with mental health problems. And when I, in my last job, moved about the English mental health system, you won't need me to point out that in many day-to-day, as it were, normal, ordinary mental health services, the priority attached to physical health care is still incredibly low. So you really do need to have a pat on the back for staying committed to this and making it happen. And what I now do as I move around the trust that I'm currently leading is try and urge the local mental health services to set their priorities a little higher so that they can deliver physical health care to the same standard of the secure services. I want to say something about the key health inequalities. You probably don't need me to tell you that perhaps one of the biggest health inequalities is the fact that people with serious mental health problems die significantly earlier. If you go to the research, you'll see the difference is something between 12 and 25 years. If you read the American studies, it's 25 years. If you read the European studies, it's probably closer to 15. But a key health inequality. And we probably need to remind ourselves that we've known about that health inequality for quite a few years. We've also known about the interventions that will make a difference. It's only relatively recently that we've begun to do anything. And I suppose I'm putting to you that failure to make a difference has been one of the big examples of stigma and discrimination. So for many years, we've had people passing in and out of high secure or secure mental health services, and we've never placed a priority on their physical health care. It's only in the last few years. And you hear a lot and you see a lot about this, different examples of stigma and discrimination. But I put to you that knowing that you're looking after people whose life outcomes are reduced and not doing anything about it is a key discrimination and a key health inequality. I'm not going to get into distributing blame as to why we haven't made progress. But what I am saying is we need to see the work that you're doing, not just in the context of improving people's physical health care, but in the context of making a real difference around discrimination and stigma. Some of the best research that I've seen tells me what I already know. And before I agreed to come and do this talk, I began to Google, look at the research, and the obvious thing that comes out to you is, and we've known this for many years, is that if you actually improve people's physical health, their mental health improves. And in my first couple of weeks at West London, I made a point of spending a bit of time in Broadmoor Hospital, meeting with and listening to service users. And many of them were very clear about how they felt about having greater attention to their physical health care. Improved self-esteem, feeling more valued. So it seems to me that we spend a lot of time in mental health talking about the difference that mental health interventions can make to people with physical health problems. You read a lot about long-term conditions. We need to make sure we don't forget one of the other obvious facts, and that if you pay attention to people with serious mental illness, to their physical illness, actually you get a marked improvement in their mental health well-being and their outcomes. You can't go very far at the moment, or for the last few years, without coming up against the model of recovery. I was very lucky to work with Sean in developing a program, IMROC. Some of you may be aware of it. For me, paying attention to people's physical health is at the centre of recovery. For lots of obvious reasons, it provides a really important platform for people to feel that they are equally valued, that they have hope and they have optimism. And I think we need to do a bit more to play in to the recovery model how physical health care, the contribution it makes. So let's move to what you probably already know, the kind of national framework. Where are we around physical health care? Well, Sean's already talked about parity of esteem. In my last job, when I had a little bit to do with no health without mental health, Paul Burstow, the then minister, coined this phrase, parity of esteem. The problem was none of us really knew what he meant, and none of us could describe it in a way that was meaningful. So we spent many hours trying to come up with a very clear definition, and obviously it was there under our nose. It is to give equal value to people's physical health and their physical health outcomes and their mental health outcomes. And parity of esteem can now be seen in the Secretary of State mandate, it can be seen in the National Commissioning Board's framework, and at a conference recently, Norman, the new Secretary of State for Health, went out of his way to labour the point around parity of esteem. So this is a key issue, a key element, and it's something that we need to remind the system of, its commitment to value mental health care and physical health care equally. The other thing that you'll be aware of, we're moving, I was going to say rapidly, it may be not that rapid, but we're moving to a system driven by outcomes. Outcomes around physical health care are going to be key to that. And in the mental health system, we have some way to go in developing robust mental health outcomes with metrics that are both consistent, reliable and understandable. But the physical health outcomes, I think, are much easier to grasp. And it may well be an important starting point for much of the mental health system. I just want to talk briefly about public mental health, about mental health and well-being. A lot of attention, quite rightly, is being given to giving people care and treatment around their existing physical health problems. We need to make sure that we don't forget the need to intervene early, to provide education, to provide public health support. Smoking, now I just want a bit of a straw poll here. How many of you are operating full smoking bans in their secure environments? Of those of you that put your hands up, on a 0 to 10 scale, I'm an ex-cognitive behaviour therapist, so I have to measure things, on a 0 to 10 scale, where 10 is that ban is working perfectly, and 0 is it's causing chaos, give me a rating, any of you? 10. Okay. So it can be done. In the organisation I work, the no smoking ban, and I have to say, after 16 weeks, this is my view, is still clunky, is still difficult, still causes major problems. I can't find easily bespoke programs to help people with serious mental health problems stop smoking. To the extent that I'm now looking to bring into the trust smoking cessation programs. That's not because the medical staff, the nurses, the psychologists are not committed to this. It's actually proving very difficult. Now, a very small percentage of the room put their hand up. I find that reassuring that the rest of us seem to be struggling. But we really do need to come together as a sub-community, if you like, and think creatively about how we can design bespoke smoking cessation programs for people with serious mental illness. Because at the moment, it seems to me it is clunky, it's difficult, and often it looks like we're diverting a very, very rare therapeutic resource to assist people to get round the no smoking programme. We're forcing ward staff, we're forcing teams into this dilemma of how much time they spend on certain activities. Diet, a little bit more audience participation here. How many people in the room are running effective diet programs, including weight loss, within their secure environments? You keep putting your hand up. Where are you from? Okay, let's all go off to Rampton, I think. Genuinely, because so the other issue is around diet and weight gain and weight loss. And again, I'm struggling to find, and they may well be there, and come and see me afterwards. I'm struggling to find bespoke programs designed around this particular group of individuals. Food remains incredibly important in the environments that you're all working in, and it's often used in a whole number of ways which seem to me may not be in line with promoting physical health. The same goes for exercise. It does seem to me we have some way to go. The final thing on this slide I want to talk about is public mental health. So we're talking about public health, I'm talking about intervening early, I'm talking about education for people's physical health, but there's a load of evidence around their public mental health, and just a plea that we don't forget that in putting programs around patients to help them with their physical health, let's not forget the evidence base around their public mental health. And anybody familiar with the Foresight report? Okay, the Foresight report was carried out about 2 or 3 years ago. It unfortunately weighs about 4 tonnes, but there is a CD which you can actually get. I'll try and make it available to the conference organisers. It summarises the evidence around public mental health and what you can do to create a public health environment for people with serious and challenging mental health issues. Primary care in mental health. It's really one of the first things I did when I started at West London was to go and visit Broadmoor, and it was really quite reassuring to bump into Alan Cohen and for him to introduce himself as Broadmoor's GP. All of the secure hospitals now have their own GPs. Regardless of the good work that Alan does, there's a really important symbolic message about us having primary care teams and primary care services in high secure hospitals. A really important message about the commitment we're making to people, bringing primary care back in to, or in many ways into the first time into these secure environments. And the effect that these teams have on staff working around them is incredibly positive. And I've been party to conversations where Alan and his team are working across that really, really critical interface of mental health and physical health. Now, I'm not saying that wouldn't have happened, but it's happening at a far faster rate. There's a sense of real collaboration, and that collaboration drives real innovation. So I just want to finish really by stating the obvious. Physical health care for people in secure settings is now a key component of care. It's a non-negotiable. 3 or 4 years ago, that was unheard of. When we now sit down with our commissioners to talk about contracts going forward, physical health care sits there in the centre of those conversations. It really is non-negotiable. And it's being played out quite rightly as an individual's right, no longer an add-on, no longer something you get to when you've tried, when you've struggled with their mental health issues. These are 2 huge achievements. I think it's now our responsibility to further refine that work and to ensure in a couple of years' time we attend a conference where this kind of commitment, this kind of right, is seen across all mental health services, not just those that provide secure care. Thank you very much.
Thank you, Sean. Last